Hello, everyone, and welcome. Thank you for joining us for this important talk on female health intelligence. Women's health is a vital topic that affects not only individuals, but families and entire communities. Today, we come together to empower and educate ourselves with practical steps to optimize our health. Across the continuum, we will learn about various areas and various organ systems today. We have an outstanding panel today who will discuss a wide array of issues, particularly as they relate to women. By sharing evidence-based information, we aim to help you make informed decisions, advocate for your well-being, and build a healthier, more resilient community. Please remember to put your questions, if you have any, in the Q&A box. And without further ado, we will go to our first speaker, who is Dr. Prieto. Dr. Prieto is an assistant professor in the Department of Medicine and Neurology, as well as a neuro-oncologist at the Perlmutter Cancer Center. She specializes in treating people with brain and spine tumors, as well as complications that can arise from cancer immunotherapy treatments. Dr. Prieto, we look forward to your talk. Thank you.
Thank you. Thank you so much for having me. I am honored to be part of this initiative. And without further delay, I'm going to share my slides, my screen with y'all. Screen one. Okay. Can you all see my screen?
Yes, it looks great.
Okay, great. Let me just I don't know how to remove the annotations here.
How to remove the what?
Oh no, it's just the closed
Oh, the
caption. I don't know how to
annotations?
remove it. Yeah, but it's okay. I have a strong accent, so maybe people can that make it easy to understand what I'm trying to say. All right, so we all have like a we're just not the person or like we're made of our well-being is made of a whole team and a wide range of experts and actions that we do to be well as a whole. So in terms of not just as a regular human, we need to have some self-care. We need to continue to have a healthy living, have mental health, have support in our teams, and sometimes take supplements, a good nutrition. But also we have our family, friends, religion, social workers, and our medicine team and oncology team in the case of cancer patients that that are the backbone of our well-being and also as a community. So it takes a village, whether there's somebody that has any disease or not. I think that is very important to consider at all times quality of life, which is a very important, very personal, and is a dynamic process. And by defining what is a good quality of life for you, uh, it makes it clear for you, makes it clear what your goals are, what you want to focus on your daily, on a daily basis, what your priorities are, and what makes you happy. And by defining this and making it public for your family members and loved ones, uh, you know, if at some point they need to make a decision on your behalf, they will know at that time what to do. And this is very important. This may change over time, but it's very important that every step of the way you share it with people that love you. And also it's important to have realistic expectations, uh, in terms of quality of life. Oh yeah, I want to travel across the world for a whole like in a month, it might not be appropriate. Or I want to run the the New York Marathon, and but I have I don't know, like I haven't exercised in a long time. So it's a very personal. It's important, but also helps getting having some goals and work towards them. Um, as I mentioned, in terms of as a patient, or patients with cancer, it takes a village, and you not only have your oncology team, but there's rehabilitation teams, psychiatry, psychology, neurologists and neuro-oncologists. Of course, I would not leave me outside. Um, you know, Supportive oncology or palliative medicine, who these are the teams that can support you from the beginning, starting your journey of your cancer journey, to help you have the manage symptoms, to have a good quality of life, to help you get through the treatments, and if and when the time comes, also prepare you and your family to cope with with every situation, every instance that happens through the journey. And hopefully it's like, oh well, we're surviving, and they will also support you on that. Nutritionist is very important. Social worker can help tremendously. There's integrative medicine specialists, music therapy, mindfulness, and support groups. Nobody goes through like only the people that are going through the same thing as you understand what you're going through. Now, in terms of enhancing, so one of the things that we want to focus it's on. Actually, this is okay. Is to prevent falls, right? So as we grow wiser, our balance skills are less are not as good as before, and um, we're at risk of fall. So the last thing that we want is to fall and break a hip. And there are like little things that we can do that can make a big difference. So one of them is balance exercises. So we start with like little exercises. I'm going to show you some in a little bit, which are like some examples that you can try. It's important to be patient with ourselves and to start slow and then build up from there. At home, it's important to every now and then take do a kind of like a reality check in a way to see, okay, is our home fall proof? If there's any tripping hazards, like rocks that are like moving all over. Maybe you want to change it for non-slip mats. Make sure there's good lighting. um, it's always very important to stay hydrated. Sometimes we forget to drink water, and also avoid making sudden movements that could trigger dizziness. Sometimes we forget that our body is not as young as our soul, and that can get us in trouble sometimes. And if you're feeling dizzy or you feel a little wobbly, don't wait until you fall and hurt yourself. So always address any medical causes. Talk to your doctors, and rehabilitation can help tremendously. But if there's um, any nutritional deficiency, like vitamin B12 deficiency, or if there's diabetes and the feet are getting numb but we do not know, those are medical conditions that can help address and prevent further or can address like the origin of the numbness that's causing the dizziness. And if in the case of that some people have gone through chemotherapy that causes this stinging sensation or numbness or pain, there are treatments that can be given to ameliorate those symptoms, but also vestibular rehabilitation can help retrain your brain to have good balance and have safety gait. One of the things that are very, very important is your beauty sleep. We all need our beauty sleep. because while we sleep, our brain gets rid of debris and all the toxins that were accumulated during the day, and also solidifies the memory. So everything that you learned on that day, it will be stored in the hard drive of the brain, so you can bring it up. Poor sleep leads to accumulation of the debris, of the toxins that increases like a low grade inflammation, or we call a smoldering inflammation, which recently has been associated with Alzheimer's and cognitive impairment. Also, if you're not having a good sleep, your brain is associated with a constant fight or flight mode. This causes chronic stress, increases the cortisol, and then it can cause metabolic syndrome, which is increasing the blood pressure, cholesterol rises, the body, and weight gain, because the body thinks, oh, I do not know when I'm going to have food next, because it's on this fight or flight mode, and then it keeps everything as a reserve, and then it's just a vicious cycle. It is very important that if you wake up not well rested, or if you're told that you snore, to see a sleep medicine specialist, because by addressing sleep apnea or any sleep disorders, your life can change dramatically. It can help with with cognition, with mood, with energy, so you can do all the things that you want. And also to help, if you're having trouble sleeping, there's some sleep hygiene techniques. You can use mindfulness, meditation. You can do some yoga, that that can help as well to relax you before sleeping. And one thing that is very important: do not use the cell phone right before you go to bed, because you can stay up until like 3 in the morning and you didn't feel it, because they're meant to engage. The same with the TV. For women that have gone through chemotherapy, chemo brain is real, and most of it a lot of times lasts. It can occur while you're on chemotherapy, but also it can linger, and the and it's manifested by short-term memory, word finding difficulty, reduced attention span and concentration, difficulty multitasking, slow processing information. And uh, us women are known to be like the master multitaskers, right? Mom can be doing work, answer the phone, cook dinner, discipline the kids, keeping the in the back of the head. Oh, we need to do this tomorrow. I need to get the uniform of the kid, or take the husband to the airport. Like everything, not only your schedule, but everybody else's schedules and extracurricular activities, and uh, and and then with chemo brain, that goes kind of like, it just makes it very difficult, and that makes people more can cause depression and anxiety, because you don't feel like yourself. But there also causes social withdrawal, loss of job, and it can affect quality of life. But I think it's important to do two things. One, give yourself grace, and they address the depression and anxiety that itself can cause cognitive issues, and but also look for other medical causes: thyroid disease, hormonal imbalance, sleep disorders that again, sometimes they can be sole seizure activity if there's any brain metastasis or something like that, and or medications that you might be taking that could be clearing your cognition. It's very important to have self-care and healthy living, and I cannot stress enough how important it is to sleep well. Quality of sleep is super important. It's quality more than quantity. It's important to get depression management. It is okay to get help. Um, Meditate, mindfulness. In the beginning, it's very difficult, but just try to do it 1 minute a day, and then you can increase. It's difficult to keep the mind quiet. But just focus on your breathing, just 1 minute, and there's a lot of tutorials in YouTube as well that are very helpful. important, very important. Let's get outside of home. It's very easy to stay inside and feel comfortable, but we need to get out of our comfort zone. Mediterranean diet can help with cognition, and it's also important, you know, to keep a balance, keep the rainbow on your plate. Also anti-inflammatory diets can also have also shown to to identify food that makes you not that makes you feel not as good as if you're not consuming them, but it's different from everybody. So it's always nice to discover those foods so you can avoid them. And this is different than allergies or intolerance. Uh, Exercise is very important. Start slow and steady, and it's very important to stay consistent. And if you go for physical therapy, as the therapist for homework that is tailored for you, and do it as much as possible. You can spread out through the day so you can save energy. Acupuncture, music therapy, pet therapy is so important. The magic of a dog or the cat, just the purring or just like um, uh, spending time with them is so beautiful. If you cannot have pets at home, you can always go to a shelter. They have these cat cafes. You can do goat yoga, baby goat yoga. Anything that that could bring you joy is important. Feeds the soul. And support groups, your friends. Now, for physical activity, it helps it's very important because it increases serotonin, which is the feel-good hormone. Improves blood flow to the brain, which supports the neuroplasticity. What does it mean? The neurons that are gone, but the ones that are left there uh, uh, are able to extend their arms amongst themselves, create a new network, and then learn more things or keep the structure and the cognition for longer. And also, it lowers the dementia risk by 30%. So we gotta get moving, even if it's on a chair. There are exercises coming. We should aim for 150 minutes moderate exercise per week. So it's like about 20 minutes a day for the weekday, or 20 minutes every day. You can go walking around the block, swing, or just dance, in your living room. Nobody's watching. And and also doing exercise helps manage blood sugar, blood pressure, and by doing so, and also reduces inflammation. And all this is important for brain health. Now, these are some exercises, and I will, the presentation is going to be available, but also some of the links for resources. And these are some exercises that you can do while sitting. So you can watch TV, and then you can do mini workouts during the commercials. And if you do this every day, just a little bit, just 5 repetitions each leg or each arm, over time you're going to see a great and impressive difference. The little things are what matter. Now we have medications that can help some of the if you're having some trouble with balance, there are medication supplements that can help. For example, Miracle Berry, which is, can enhance taste, which is for quality of life. For peripheral neuropathy, there are medications that can help. If you're going through chemotherapy, ice chips and cold gloves can help during carboplatin, and oxaliplatin infusions. It can help also, like with a heavy blanket at night, can help you sleep better. Alpha lipoic acid, it helps the wrapping of the nerves, that is lost with the chemotherapies. It takes time though. There are and there are medications that can help with energy, such as Ampera, modafinil, can help, but and sometimes there are like some stimulants like modafinil or Provigil or Nuvigil, which is the newer version. But always, even if it is like something natural or organic, talk to your doctor about any supplement, because not all of them are benign, or some of them might interfere with some of your medications. So here we have a resource that is very helpful. These are some of the brain games that you can get and applications on your phone or on your tablet. That some of them are free, some of them are paid, but they depending on what you're looking for, if it's fine motor skill, visual perception, there are all sorts of them. There's pocket yoga. It's like amazing. Gratitude journal also is very helpful. So this is the link for their website. And for the caregivers, it's important also to take care of yourself. Caregiver burnout is real. Sometimes we are so overwhelmed that we reach a breaking point, and then because we didn't care for ourselves, we cannot care for others. So it is so and there's this guilt, right? If you take care of yourself, you feel guilty. But it's okay to take a break. It's okay to accept family and friend support. Everybody wants to help, but you keep pushing. Nobody's going to dare to even ask. Take at least 20 minutes of daily for yourself. You can do your walk, or you can do your dancing in the living room. Stay social. Talk to your friends. Go outside. Enjoy the sun. And there's caregiver support, and social worker has resources, and we have many services, integrative services at NYU, nutrition, everything at hand. Just ask. It's available, and you'll be surprised. Some of these are already covered by insurance or even free. These are the numbers for some of the support services. And some of resources for caregiver and patients, and I can add some of the hygiene in sleep as well.
Our next speaker is Dr. Chowdhury, who is an assistant professor in the Division of Endocrinology at NYU Langone and practices at the Center for Women's Health. She completed her fellowship in endocrinology, diabetes, and metabolism at the NYU Medical Center, and later completed an additional fellowship in menopause, hormonal disorders, and women's health at Columbia University. We welcome Dr. Chowdhury. Thank you.
Hi, good evening. Thank you for having me. Thank you to the organizers. I'm going to speak to you today about the thyroid in the neck, and it produces thyroid hormones and calcitonin, which is involved in calcium regulation. The parathyroid, so this here is a posterior view. The parathyroids are 4 small glands located behind the thyroid gland. Typically, there are 2 pairs. There's a superior pair and an inferior pair, and they produce parathyroid hormone, which also regulates calcium metabolism. So in this, can be linked to thyroid dysfunction. Also, hormone levels and pregnancy can affect thyroid function. Thyroid hormones are crucial for fetal brain development, and that thyroid disorders are more common with aging. And by this year, an estimated 1.1 billion women worldwide will be postmenopausal, and that's a very significant segment of the global population. So the primary hormones that are secreted by the thyroid gland are thyroxine, or T4, and triiodothyronine, or T3. These hormones are essential for growth and for development, and they also regulate various bodily functions, including metabolism, as well as the cardiac, digestive, nervous system, musculoskeletal, and reproductive systems. Specifically in regards to metabolism, the thyroid hormones regulate basal metabolic. The other hormone secreted by the thyroid gland is calcitonin. And this, is part of calcium regulation. It lowers blood calcium levels by inhibiting bone resorption. So I wanted to spend a moment discussing thyroid hormone regulation, as this is a question that comes up frequently in my clinical practice. So TRH, or thyroid releasing hormone, is secreted by the hypothalamus stimulating hormone. And TSH interacts with thyroid gland receptors to influence the production of thyroid hormones, namely T4 and T3. There is an inverse relationship, or a negative feedback, between the thyroid hormone levels and the production of TSH. And so what I mean by this is, if the thyroid gland is producing high amounts of thyroid hormone, it feeds back negatively to the hypothalamus and the pituitary gland, and they respond by secreting more TSH. So, TSH really is the initial and best screening test for thyroid dysfunction, but sometimes it's a little counterintuitive. So, if you have a high TSH, we'll do further tests to confirm, but typically that indicates a low thyroid state. If you have a low TSH, then typically that indicates a high thyroid state. Hyperthyroidism is overproduction of thyroid hormone from the thyroid gland. It's often due to Graves' disease or autoimmune hyperthyroidism. Can also be due to, a toxic nodule or a toxic multinodular goiter. So areas within the thyroid gland develop, autonomous function. Rarely, a pituitary tumor can secrete, high amounts of TSH that can lead to a high thyroid state. In pregnancy, the pregnancy hormone HCG tends to peak at 9 to 11 weeks of gestation. And it does have some homology with a receptor on the thyroid gland and can cause a brief period of hyperthyroidism. Usually does not need to be treated. It's typically self-limited. And another interesting but rare cause of hyperthyroidism is an entity called struma ovary. And this is where an ovarian tumor can actually produce thyroid hormone. Symptoms are often unintentional weight loss despite increased appetite, insomnia, anxiety, palpitations, tremors, heat intolerance, increased frequency of bowel movements, change in menstrual cycles. All can be suggestive of thyroid dysfunction. And usual treatment is, with beta blockers. These medicines can kind of block the adrenergic effects of a high thyroid state. We often will use anti-thyroid medicines that block the production of thyroid hormone, or radioactive iodine or surgery. So immunotherapy, as we all know, has been revolutionary in regards to cancer care. There are, some immunotherapeutics that can cause thyroid dysfunction, namely the immune checkpoint inhibitors. It can be seen with the drugs that are listed here. And the most common endocrine disorders are, hypothyroidism, hyperthyroidism, and hypophysitis or inflammation of the pituitary gland. So patients might develop inflammation of the thyroid itself or inflammation of the pituitary gland, both of which can lead to thyroid dysfunction. Typically, it's hypothyroidism, so the thyroid becomes less capable of producing thyroid hormone, or because of pituitary inflammation, the pituitary gland doesn't secrete that necessary hormone, TSH, which then leads to a downstream low thyroid state. Sometimes you can see a biphasic pattern where you'll have a brief period of high thyroid levels. Again, it's typically self-limited, not that severe, and we usually don't treat it, followed by a more durable, low thyroid state, which we usually do treat. And very rarely you can have, a sustained high thyroid state. So, when patients are receiving these medicines, my oncology colleagues are great about monitoring thyroid levels prior to and during therapy. And treatment is with thyroid hormone. So thyroid nodules, these are really common. You may palpate a lump in your neck that you should get checked out. Your doctor may feel it during a physical examination. They're often incidentally noted as well, on imaging done for other reasons. Thankfully, most of these thyroid nodules are benign. And we now have a wealth of data that helps us in terms of risk stratifying these nodules. We can look at some nodules and know right away they don't even require any further imaging or surveillance. Others that may just require ultrasound surveillance, after 6, 12, months, 24 months. And others that have some risk, features that render them higher risk and, will warrant a fine needle aspiration biopsy. Even with a biopsy, it's not always entirely clear. Some nodules are decidedly benign, most nodules, some are decidedly cancer, but there is a gray area of indeterminate nodules. Historically, we were sending these patients for surgery and sometimes unnecessarily. But with the advent of molecular testing, it's been really helpful in terms of risk stratifying these nodules further. If there is a high-risk mutation present, I can feel confident that I'm sending the patient for surgery appropriately. If no high-risk mutation is identified, then I feel confident reassuring the patient that we can just continue to surveil that nodule. So thyroid cancer is the most common endocrine malignancy. There are 4 subtypes. Papillary thyroid cancer is by far the most common. It has an excellent prognosis. It's highly treatable. Follicular thyroid cancer is also fairly common with a good prognosis. Medullary thyroid cancer comes from those C cells that I mentioned earlier, and they produce calcitonin. These can be seen in hereditary syndromes such as multiple endocrine neoplasia, which is also associated with other endocrine tumors. And finally, anaplastic cancer, which thankfully is very rare as it is highly aggressive. And diagnosis, there are some ultrasound features that make, an ultrasound, a nodule high risk appearing. We'll confirm with biopsy and molecular testing. Treatment is largely subtype dependent. Most often it's surgery. In the setting of papillary or follicular cancers, we will treat with radioactive iodine. Sometimes we will need to use systemic therapies in advanced thyroid cancers. That's not often, and we'll usually work closely with our oncology colleagues in that setting. The parathyroid glands. These small but mighty glands, secrete parathyroid hormone, which regulates the calcium and phosphorus balance in the body. Calcium is essential, not just for bones, but calcium is needed for, muscle contraction, cardiac muscle contraction, nerve conduction, amongst other things. And so if calcium levels are not sufficient, the body responds by secreting more PTH. And this increases blood calcium by stimulating bone resorption, increasing calcium absorption from the kidney, and increasing calcium absorption from the gut as well. You can develop parathyroid disorders. Hyperparathyroidism, is overproduction of PTH, and essentially one or more of these glands becomes overactive. It's not listening to the usual signals, and this can cause, high blood calcium, high urine calcium, kidney stones, kidney problems, osteoporosis. Usual treatment is surgery, sometimes in older patients where the hyperparathyroidism is mild and clinical complications are not present, we may observe. And very rarely we'll use medical therapy in this setting. I wanted to make a point about secondary hyperparathyroidism. This is sort of an appropriate elevation in PTH if you see this in your lab testing in the setting of low calcium intake or low vitamin D. I care passionately about this because I take care of a lot of patients with osteoporosis, and if we don't replete calcium and vitamin D adequately, then the sustained high PTH levels can really worsen osteoporosis. And then finally, hypoparathyroidism or underproduction of PTH sometimes can be seen in infancy as part of a congenital syndrome. Acquired causes can be surgery, surgery for the thyroid itself or other head and neck cancers, where you can disrupt the blood supply to the parathyroid glands, or the parathyroids just need to come out for that surgical indication. Autoimmune disease can also result in low PTH. And if this develops, it can be dangerous. It's not just low calcium levels. It can lead to cardiac rhythm problems, muscle contractility issues, and seizures. And the usual treatment is with, higher dose calcium and activated vitamin D supplementation. So I thank you for your attention. And this last photo here is a picture of my wonderful colleagues that I have the privilege to work with at the Women's Center. Thank you.
Dr. Bloom is an advanced heart failure cardiologist and the system director for the NYU Health Cardiology Oncology Program, which was founded in December 2023. The program serves the needs of patients at risk or with existing cardiovascular disease and the diagnosis of cancer, with a special focus on the needs of cancer survivors, with the goal of limiting interruption of cancer therapy and improving the lives of her patients. She sees patients on both Long Island and Manhattan campuses. Dr. Bloom.
And I'm going to try and just get us back on time. So I'm going to talk quickly and I'm going to give you a lot of information, but here we go. Next slide. So the objectives of this talk, I want you guys at the end of this to know the facts about heart disease in women, to teach you about the traditional risk factors, but also women-specific risk factors. I'd like to highlight some strategies for lowering your risk, and then at the end, we'll briefly discuss how cancer and cardiac risk sort of intersect with all of this. Next slide. So I want to start with a case. 42-year-old woman, never seen a doctor. She's active and healthy. She's a single mom. She has 2 young boys and one has special needs. She has a stressful job with a highly demanding boss. And one morning she's getting her kids ready for school. She feels some fluttering in her chest, a little bit of shortness of breath. She drinks some water. She feels better. She keeps going, plugging along, takes her kids to school, goes to work. On and off the whole day, she feels some palpitation, some fatigue, but she has a deadline, so she pushes through. Sound familiar so far? She reaches home after work. She's a little nauseous. She has a little more shortness of breath. She briefly mentions to her friend on the phone, who says it's probably stress and anxiety. She goes to sleep. She wakes up the next morning. She's severely fatigued. She calls in sick and she goes to see her family doctor. Her family doctor does her blood pressure, which is a little bit elevated, but she has a normal physical exam. They give her some prescription for anxiety and they tell her to come back for a physical at some, time later. She goes home. She is profoundly dizzy. She is clammy. She is cold. She almost passes out. She calls 911. She's rushed to the emergency room. She's found to have a heart attack. This is what her catheterization shows. And I know you guys are not experts, but hopefully you can appreciate that on the left, she has a complete blockage of the main artery of her heart. And on the right, when they open up the blockage, this is what it looks like. And hopefully you believe me when I tell you this is actually a real patient of mine that I have taken care of for many years. And thankfully she's okay. But this probably resounds with a lot of you because this is how women present with heart disease. Women's hearts are different than men's. So how common do you think this scenario is? It's a man's problem. It's probably just indigestion. She's too young and fit. She has no family history. And we all think, no way this can happen to us. But we're smart, powerful women, and we need to know the facts. So heart disease is the leading cause of death in women. It affects about 1 in every 4 women who die of something. They're dying of heart disease. That's approximately 1 woman every minute. 1 in 3 women over the age of 20 have some form of cardiovascular disease, but only half of women know that they have heart disease. Heart disease is often thought to be a man's disease, but around the same number of women and men die each year of heart disease in the United States. And about 2/3 of women who die suddenly of coronary heart disease have no previous symptoms. So even if you don't have symptoms, you may be at risk. We know that even though breast cancer is super common in women, affecting about 1 in 30 women, heart disease affects about 1 in 3. We also know that despite increases in awareness, only about half of women know that heart disease is the #1 killer. Women aged 45 and younger are more likely than men to die within a year of their first heart attack. And we know that coronary heart disease remains the #1 killer of women in the United States. 90% of women have at least one, but if not, more risk factors. Our symptoms may be the same, but they're typically not the same as a man. So women are more likely to present with atypical symptoms of an acute heart attack. So while a man kind of reads the textbook and is sort of the typical, you're seeing it in a movie type of chest pain. He's ashen, he's gray, he's grabbing his chest. He has severe chest pain. A woman is less likely to present that way. She's more likely to present with fatigue, some unusual shortness of breath, some upper back and chest pain, flu-like symptoms, dizziness, weakness, thinking that she has indigestion, some palpitations. I actually also want to say that I always ask my women in the office, sometimes it can just feel like your bra is too tight. Like the whole day you feel like you need to loosen your bra, even though it's not that your bra is too tight, but it's a very typical thing to see in a woman presenting with heart disease. Female versus male deaths from cardiovascular causes, you can see that somewhere around the 80s, women surpassed men in terms of death from cardiovascular causes. And while the overall trend is that more people are dying less often from cardiovascular disease, the point is that any given time and any given year over the last couple of decades, a woman is more likely to die of cardiovascular disease than a man. So what do we know about traditional risk factors? Well, I want to talk to you a little bit about high blood pressure, high cholesterol, diabetes, obesity, and smoking. I'm going to go quickly through each of these. Some of these you'll hear about in other presentations, but I just want to make you aware of them. Next slide. How to lower your risk with high blood pressure? Well, you should be checking your blood pressure at least once a year with your primary care doctor. You should get active and aim for 150 minutes per week of physical activity, which we'll talk about a little more. Avoid things like smoking and very much limit your alcohol. Manage stress levels and sleep. I know it's easier said than done. We all have problems with this. If you are prescribed medication for high blood pressure, please don't skip your doses. We don't prescribe these like antibiotics where you take it for a couple weeks and then you stop. Blood pressure medicine are typically lifelong medications. And just make sure that you restrict your salt, because we know that salt restriction lowers risk of high blood pressure even more effectively in women than men. High cholesterol, very, very briefly, it's important to know the numbers. So we talk a lot about total cholesterol, which we like to keep below 200. We also talk about bad cholesterol, LDL cholesterol, which is the cholesterol that builds up in your arteries and raises risk. And ideally, we like to keep this less than 100. In patients that have other risk factors or who are diabetic or who have known blockages in the arteries or a history of a stroke or a heart attack, we drive this number even lower to less than 70. The lower, the better. The good cholesterol, which protects the arteries, we like to keep this above 40 in men and above 50 in women, ideally, and the higher the better, but it's hard to adjust this. A lot of this number is genetic. And triglycerides, we mostly get from extra fat from our food, but we like to keep the levels less than 150. How should we lower our risk with high cholesterol? Well, I think the usual things are important: eating more fruits and vegetables, whole grains, choosing healthy fats like olive oil, nuts, and fish. Again, keep active more than 150 minutes per week. Ideally, avoid smoking, limit alcohol, and take medications like statins. This should all be sort of repetitive for you at this point, similar to what we do about blood pressure. Diabetes, I think that if Dr. Chowdhury gets on again, hopefully she'll talk about this a little. I don't want to spend too much time on this, but suffice it to say, in the world of cardiac health, in a woman who has diabetes, she is much more likely to have a cardiovascular event, more likely to have heart failure, have blockages in the arteries, have a heart attack, or overall have higher mortality. So we really need to identify diabetes early and treat diabetes very aggressively, especially in our female patients. Obesity is more common in women. It has a greater impact on heart disease in women than men. It's more inactivity in women is more prevalent in women than men, and exercise can actually more effectively lower risk in women than men. So if you're exercising and you're next to your husband exercising or your partner exercising, you are more likely with exercise to lower your risk of cardiovascular disease than the man next to you. BMI, you should know your BMI. A healthy weight is a BMI of around 20 to 25. So really try to keep your BMI within a healthy range. And if you're overweight, you want to talk to your doctor about medications or other strategies that can lower your BMI. But also I want to say to this crowd, because I think women really, we're very hard on ourselves and we tend to not have realistic goals. Anytime you try to lose weight too rapidly, it's very rarely sustainable. Remember, to lose 1 pound, you have to limit 3,500 calories. So really you need to subtract about 500 calories per day from your diet to expect to lose a pound a week. And honestly, I counsel my patients a lot on this. If you want to lose weight effectively, you do it slowly and in a meaningful and in a realistic way. So limit by about 100 calories a day to start, and then 200, and then 300. And then the more we do this over time, the more effective we are at losing weight. But again, like I said before, if you're obese or you're overweight, you should also ask your doctor about medical therapy. We've come a long way in terms of medical therapy, and just be realistic with yourself. Get moving. The American Heart Association recommends about 30 to 40 minutes of moderate to vigorous exercise 3 to 4 times a week. This equals out to about 150 minutes per week. And honestly, you can split this up any which way you want to. So I always tell my patients 20 to 30 minutes a day. And if you can only do 5 or 10 minutes in little spurts, that's better than doing nothing at all. Maintaining a healthy weight is really, really key. And in order to do this, you have to stay active. You have to consume less calories and you have to burn more calories by exercising and being active. Smoking, don't do it. Smoking increases the risk of developing heart disease or stroke by up to 4 times the amount as in women who don't smoke. Women who smoke have a 25% higher risk of developing heart disease as compared to men who smoke. Nicotine also increases blood pressure and heart rate. It directly damages blood vessels, and it lowers your exercise tolerance if you smoke. Know your numbers. We talked a little bit about this, but I think it's really important that women be empowered to know their numbers. Know what your BMI is and know what you want it to be. know what your goal blood pressure is. We try to keep blood pressure around 120 as the top number and around 80 or less as the bottom number. Higher than that, and it's really problematic. So really know what your blood pressure is. We like to maintain fasting blood glucose. I'm sure Dr. Chowdhury will talk about this as well, less than 100. And we need to know our cholesterol numbers and our good and our bad cholesterol, like I said before. There are two main risk calculators that we use. One is called ASCVD risk, and a newer one is called the Prevent Risk Score. It is important. You could, by the way, know your numbers and calculate these both online. You can look these up online and calculate it yourself. But if you can't do that, it is important to ask your doctor to do this for you. But what I will say is what is important to know is that women have other non-traditional risk factors like polycystic ovarian disease, oral contraceptive use, anxiety, depression, autoimmune diseases, pregnancy complications, breast cancer therapy, frailty, and those things are not accounted for in these traditional risk scores. So I want you to understand that even though you know what your risk score is, we're probably under accounting for risk in women. So it is important to recognize this. Switching gears for just a couple slides before I end, part of my job is running the cardio-oncology program here at NYU. I am a cardiologist who is very in tune with the needs of cancer patients and cancer survivors as their cardiac care intersects with their cancer. So it's important to understand that cardiac toxicity can very much limit either your ability to receive and complete your cancer therapy, but also can limit survival in cancer survivorship. So in women who have heart disease, it can limit overall survivorship, both from cancer standpoint, but also from cardiovascular standpoint. There's a growing population of cancer survivors. I'm sure a lot of people on this call are cancer survivors. Dr. Myers and I work a lot with this population because it is important to know that survivors are at a unique risk of many different complications, including from the heart. Heart disease and breast cancer intersect in so many different ways, but most women that have heart disease or who are at risk of heart disease are not even seeing a cardiologist before, during, or after their breast cancer treatment. And there are a lot of identifiable risk factors that are overlapping. So which cancer patients are at highest risk of cardiovascular disease? People with cancer plus high blood pressure, diabetes, smoking history, high cholesterol, family history of heart disease, childhood survivors of cancer who especially have received certain types of chemotherapy or radiation to the chest or breast or to the whole body. Studies show that if we detect cardiac disease early in patients with cancer and survivors of cancer, they have a higher likelihood of continuing cancer therapy without interruption, and also they have better overall survival. But we need to personalize the approach to patients like this, and we need to improve awareness and early referral. So if you are seeing your oncologist and you're not seeing a cardiologist, ask your oncologist, or honestly, just reach out to us directly, because I'm more than happy to either see you in the clinic or I'm happy to send you to our cardiac prevention colleagues. So speak with your oncologist about whether you should see a cardiologist as part of your cancer treatment, and call us to schedule an appointment. We're always happy to chat with you or send you to the right type of cardiologist to see you. So in summary, heart disease is the leading cause of death in women. Women are at an increased risk, both with traditional risk factors as well as non-traditional risk factors that are specific to women. It's important to empower yourselves to know your risk, to talk to your doctor about preventing heart disease. More than 80% of cardiovascular disease is preventable. So schedule a well woman visit with your primary or with your cardiologist to screen and identify to treat any risk factors that we have discussed. So here's the bottom line. When it comes to your heart health, trust your gut and your intuition, be your own best advocate, always better safe than sorry. And there are many instances where people have been too late, but 90% of women who have had a heart attack report that they had a feeling or they felt something wasn't right. So trust your instinct. Thank you very much for having me here. It's always a pleasure to do these things. I feel like the people that are on these webinars are always the most well-informed patients. And happy to help you guys in any way that I can, and enjoy the rest of the webinar. Thank you.
Thank you so much, Dr. Bloom. And as you said, we do work closely together for our patients, and this is such a very important topic. Our next speaker is Dr. Wisnia, who is a board-certified dermatologist and a clinical assistant professor in the Ronald O. Perelman Department of Dermatology at NYU Grossman School of Medicine. She sees patients in her own private practice at 83rd and 5th on Manhattan's Upper East Side. Dr. Wisnia, welcome.
Thank you so much for having me. I'm excited to talk to everyone about skin health. And a brief outline, we're going to be speaking about how to care for aging skin and skin cancer screening. So the main takeaway for this is being very careful with sun exposure. So this has to do with wearing sunscreen, which we'll get into, what's important to look for on the tube, and also practicing sun safety. Moisturization is, of course, important, and seeing a board-certified dermatologist regularly is also crucial. We can help with regular skin exams, different laser treatments, and even chemotherapeutic creams that can target sun damage. So it's important to use a broad spectrum water-resistant sunscreen with SPF of at least 30 to all of your exposed skin. So we hear these words a lot, broad spectrum. What does that mean? It provides protection from both UVA and UVB rays. I say this all day and I mean it. It's important to reapply every 2 hours, especially after you're active, after swimming or sweating. And I think protective clothing is becoming much more popular, but probably still a little bit underused. There's really nothing that can beat a long sleeve shirt, pants, a wide brim hat, and sunglasses. Even sunscreen, I think this is superior. The other thing I tell a lot of my patients who like to be active outside is keep in mind the time of day that you're outside. Obviously, we want everyone to enjoy the summertime, but the rays are strongest between 10 in the morning and 4 in the afternoon. And if your shadow appears to be shorter than you are, try to get some shade. In New York City, you'll see a lot of people moving to the shady side of the street, or when you're waiting to cross the street, kind of standing backwards in the shade. Those are dermatologists and other people who are very careful in the sun. So try to be part of that group. I've been mentioning a lot about the summer and sun exposure. It's also important if you're near the water, snow, or sand, because they reflect and intensify the damaging rays of the sun. A lot of patients will ask about vitamin D. Should they be in the sun so that they get vitamin D? And the American Academy of Dermatology recommends not getting vitamin D through sun exposure. Don't seek the sun. Obviously, there will be some conversion, but to take supplements. Another feature of sun smartness is not tanning, not to go to tanning beds. If this is something you've done before, it's helpful to mention at your appointment, but not something I would ever encourage. We have a saying to check your birthday suit on your birthday. I don't know if it needs to be on your birthday, but at least once a year, try to schedule an appointment for a full skin exam with a dermatologist. And if you notice anything yourself in between the appointments, obviously, don't wait until your birthday. All of these things are to prevent skin cancer. So you see the X is through a tanning bed. We have a picture of sunscreen, a sun umbrella at the beach, someone wearing a hat that probably isn't the best option. We want something where you're not getting sun through like a straw hat, for example. This, I think, is a nice guide to what to look for when you're in CVS or the grocery store trying to find sunscreen. So a lot of patients will use makeup that has SPF of 15 or a moisturizer. I think if you're going to go ahead and wear sunscreen, you might as well try to find one that's at least 30. This can be trial and error. What one person likes, someone else may not like. Someone may find it irritating. But once you find one that's easy and you're happy to put on every day, that's what I would stick with. Again, we spoke about broad spectrum, so you want to see that on the bottle. And you also want to see that it's water resistant. A mnemonic and a way to remember how much sunscreen to use is 1 ounce. And that's actually the size of a shot glass. And that's considered the amount needed to cover all the exposed areas of the body. So in terms of skin cancer screenings, just to switch gears here, we'll go through very quickly different types of skin cancer and how we detect it. So skin cancer is the most common cancer in the US, and there are several kinds, the most common of which are squamous cell carcinoma, basal cell carcinoma, and melanoma. So a total body skin exam is a screening for malignancy. It helps the patient and doctor assess for skin cancer risk, and it can also provide clues to other diagnoses. We recommend this to everyone once a year, and we sometimes do it more frequently if patients have a history of skin cancer or a history of melanoma. In patients newly diagnosed with melanoma, we'll do the exam every 3 months for a couple of years, and then we typically move to every 6 months. If you've had an exam, you may see your dermatologist holding a little light, and this is called a dermatoscope. It's a handheld illuminated microscope that has non-invasive diagnostic technique that allows for the observation of morphologic features that are not visible to the naked eye. And it's been shown to improve sensitivity for melanoma detection compared to the naked eye. This is a mnemonic for features that are concerning for melanoma. If certain features are met, that does not mean it is a melanoma. I like to think of this as sort of a guide. If you're concerned about something and it meets one of these features, it's worth bringing up to your dermatologist. But sometimes people get very nervous that something has multiple colors, and it actually ends up being benign. So I don't want anyone to feel like this is a sure thing. So A stands for asymmetry, B is for border, C is for color, D is for diameter, and E is for evolving. Some people also like to mention to think of D as for getting darker and C is for change. Obviously, this was designed to fit the alphabet. And you can see in these photos, all of these features are met and it would be worth bringing up at an appointment. We encourage patients to perform exams monthly. Obviously, we know it's hard to examine certain areas like your back and your scalp, but it's meant just to be something that you kind of check in and see if you've noticed any changes. If you do notice any changes, that would be a reason to see the dermatologist sooner. And these exams are not meant to replace seeing a dermatologist, but rather to be in addition. And the biggest takeaway of the whole talk that I'm giving is if you are concerned by any lesion, please have it evaluated by a dermatologist. You can detect change the best in yourself, you know your skin the best, and you should trust your eye. This is a little schematic that goes over how to perform a skin exam. This is not the only way, but I find this helpful to explain it. So basically you want to examine your body in a full-length mirror, front and back, and then the right and left sides with your arms raised. Then you want to check your underarms, forearms, and palms. You can bend your elbows to do this. Then you can sit down, look at the backs of your legs and feet, look in between your toes and at the soles of your feet. You can use a hand mirror to examine your neck and scalp. So you can examine the back of your neck and scalp with a hand mirror and part the hair for a closer look. This is very challenging to really adequately do, but it's worth still incorporating. And then finally, you can use a hand mirror to check your back and buttocks. These are some resources you can use for really important information about skin cancer and many different schematics and resources for patients that I would recommend. And thank you again for including me in this webinar, and I look forward to hearing the other speakers.
Thank you, Dr. Wisnia. Our next speaker is Dr. Didania. She's an associate professor of ophthalmology at NYU Langone Health. She's actively involved in caring for patients and research, as well as teaching and serving as director of retinal surgery fellowship. Dr. Didania.
Thank you. So I'm going to be speaking today about how we can care for our aging eyes and things to look out for. What should indicate to us that we need to go in to be seen sooner. So very quickly, I wanted to put this picture up of the eye. It's a diagram. And For the sake of this talk and for the sake of a lot of the things that we do when it surrounds the eye, we kind of sometimes divide the eye up into the front of the eye. So that's the cornea, the lens, the anterior chamber, and the back of the eye, and that's the retina and the choroid. So what are some things that we can see with aging that affect the front of the eye? Many of us have heard of cataracts, cataract surgery. We can talk a little bit more about what we're looking for, what we're thinking about. Glaucoma affects the front of the age commonly with aging, as does dry eye syndrome. And then we talk about the back of the eye. And what we really think about is macular degeneration, an age-related condition, retinal detachment, diabetic retinopathy, and then medication toxicity. So what is a cataract? Well, we have a lens in our eye, and it's clear when we're born and for when we're young. And this lens bends light so we can see. As we age, just like we develop wrinkles and white hair, that lens slowly starts to turn more yellow. And patients may experience symptoms of clouding in their vision or blurred vision. They may say that they require more light to read. No matter how high I turn up the light in the evening, I just can't read on my book. They may experience glare and halos, especially when driving at night with the oncoming headlights, or colors may appear more faded. Now, the risk of cataract in men is equal to the risk in women. When we look and think about it, and you'll see this kind of theme occur throughout other conditions, women live longer than men on average. And so when we look at the prevalence or how common this is, a lot of the reports will show that it may be more common in women. But the reality is that they have the equal amount of risk. So one main thing I'm going to split this up into is what is reversible loss of vision and what is irreversible loss of vision. So a cataract is a reversible loss of vision. And how do we reverse it? Well, we can go in and we can do cataract surgery. This is the second most commonly performed surgery in the United States. It's a same-day surgery. You come in, the surgery is about anywhere from 5 to 15 minutes. You go home that same day and you see your doctor the next day. And it has a very low rate of complications. This image here is a lens, it's an artificial lens. So when cataract surgery is performed, it's an actual surgery. It's not just a laser procedure, although laser can be added on to the surgery. We remove the lens from the eye and we put this sort of implant in its place so that it can still bend light and patients can continue to see. So how can you slow the development of cataract? Well, we talk about wearing sunglasses and protective eyewear. This is something that starts off at a young age and continues throughout. But at any point in time, it's still recommended that once you start thinking about it, wear sunglasses and protective eyewear. And we also talk about quitting smoking, as patients who smoke can have a higher risk or cataracts develop at an earlier stage. So then we move on to glaucoma. So this is actually a leading cause of blindness for people over the age of 60. There are two main types of glaucoma that I'm going to discuss, and more commonly the way that we organize this. There's open angle and closed angle, and they have very different symptoms. Often, open angle glaucoma has no symptoms. Patients have no idea that they're developing this condition. And so what indicates to us that someone might be developing this condition? They may have a family history. Maybe siblings have the condition, parents or grandparents had glaucoma. So that cues us into someone's risk factors for this. Often this can be diagnosed on an eye exam. If you go in for your annual eye exam or an eye exam, let's say at 50 or later, we can detect whether or not a patient has open angle glaucoma. Then we have angle closure glaucoma, which is the much less common type. And this usually has sudden symptoms. So patients may suddenly develop pain, often in dark conditions when the pupil dilates and it closes off the drainage for the eye. They may have sudden onset of blurred vision, often in the darkness when the pupil dilates. Terrible headache that comes on all of a sudden, nausea and vomiting, or halos around lights that can happen all of a sudden. And this diagram here shows how fluid is made within the eye, just like our bone marrow is necessary to make blood, and how that fluid has to drain around to the front of the eye. When that fluid doesn't drain from the eye well, the pressure can build up. And this is what damages the optic nerve, which is what brings the message from our eye to our brain. When that's damaged, patients can have a problem with their vision. And so now if we could just do one click. Glaucoma is an irreversible loss of vision. And so this is important to remember. This is something we want to catch early. We want to treat early so that we don't lose vision over time. Patients tend to lose their peripheral vision first, which is often why there are no symptoms, because it starts off very far out in the periphery until it gets to be very severe, and then it may affect your central vision. So what are some risk factors for glaucoma? I already touched upon a few. So one of them is family history. So really knowing, did your parents have this condition? Do you have siblings with this condition? Eye injury, any major trauma to the eye can put you at risk of glaucoma because it can cause damage or scarring to the drainage network of the eye. Long-term steroid medication use for the eyes or for the body, diabetes, migraines, high blood pressure, and then African, Hispanic, or Asian heritage can also be risk factors for glaucoma. This is another condition that you'll continue to see where the risk in men and women is equal. Women tend to live longer, so we see this at a higher prevalence. But if you look at it on a year-to-year basis, that risk is equal. What are our treatments? Well, eye drops is often where we start. And I have the picture of these bottles here because a lot of times when patients come in for their doctor's appointment or their glaucoma follow-up, they may not bring their medications with them, but we identify what class or what type of medications patients are on based on the color of the top. And so they might say, oh, well, I'm on this blue top medication twice a day, or this pink top or purple top medication 3 times a day. That gives us an idea. And it's also really important for patients because they're able to identify what medications they're using. And they might know over time, well, oh, I can see the blue cap. So this is the one I need to take 3 times a day. This is, we can also do an office-based laser procedure sometimes. And then our kind of more final intervention would be surgery. That's more invasive. And so that's not generally the first procedure that we jump to. So I move on to dry eye. So we have tears on the eyes, on the eye that keeps the surface nice, smooth, and clear. Tear production decreases with aging, especially after the age of 40. So patients may describe a burning or stinging in their eyes, that they have blurred vision, especially while reading. Well, why are we noticing it more while reading? When you're reading or when you're focused on an activity, you're blinking less frequently. And if you're blinking less frequently, you're not lubricating your eye as much. That may be when you notice that your vision is blurring. And so it's a good reminder, just blink a little bit more frequently. Oftentimes we tell patients to maybe keep some lubricating eye drops next to where they'll be reading, or if they're at a computer all day, to kind of help with that. Other symptoms, a gritty sensation in the eyes, if there's something in there like sand, redness, tear overflow. So you may wonder, well, if I have dry eye, why are my tears overflowing? The tears your eyes are making are not working well. And so when they're not working well, your body and your eyes are trying to produce more tears that still don't work well. And so they run down your face. So then we really have to talk about how to get better quality tears so that you don't have dry eye. And it may be painful to wear contact lenses. If you've been wearing contact lenses for a while and all of a sudden or over time it becomes more painful, that might indicate that your eyes are becoming more and more dry. And this is a reversible cause of vision for the most part. If it's very, very severe, that could be a different story, but dry eye syndrome in general is a reversible cause of vision. So what are some causes? Well, LASIK surgery can contribute to how bad or how early dry eye develops. Long-term contact lens wear. If there are immune conditions, there are certain conditions, for example, Sjogren's syndrome, where patients may not be creating tears as well. If you're spending an extended time reading, we talked about how that can contribute to dry eye. And then certain medications can contribute to dry eye, especially at this time of year when patients are taking medications for allergies. That actually can dry up your eyes, and you may need lubricating drops more frequently to be comfortable. All right, so what are some treatments? Lubricating drops. There are various kinds of lubricating drops. You can over-the-counter buy bottles that look like a regular eye drop bottle. Those are lubricating drops that work quite well. We ask patients to not to use those more than 4 or 5 times a day. The reason for that is those larger bottles have preservative in them, and over time that may become irritating. So if you are finding that you need these drops more frequently, there are preservative-free vials that you can buy that may not cause as much irritation to the eyes with frequent use. Patients can put in an ointment. So sometimes your doctor might recommend you put in an ointment before you go to bed. One caution I would make is that ointment can blur your vision. If you think about putting something like Vaseline in your eye, your vision blurs. You don't want to fall when you do that. So it's really, really critical. We can talk about putting plugs in the eyes or other drops that can increase tear production. How do you limit dry eye? Well, limit the use of a hair dryer near your face, or having really a lot of heat in your room or in your apartment. Using a humidifier can help. Protecting your eyes from the wind. increasing your blink frequency, and keeping your eyelids clean, gently washing the eyelashes so it clears away any debris. So those glands that produce our tears work well. So then we move on to the back of the eye. So age-related macular degeneration is something that many of us hear about, many of your friends may be talking about. This is an age-related condition affecting the central vision. This is a condition that you see after the age of 50, not before the age of 50. Now, there are two forms. There's a dry form, which is what 80% of patients have, and it's where there's thinning of the retina. And then there's the wet form, which is where there's new blood vessel growth. With the wet form, that contributes to 90% of vision loss from macular degeneration. So most patients who have the dry form generally do fairly well. This grid on the side can show you kind of what a patient who has macular degeneration may see. Those lines may be wavy, they may feel distorted. There may be dark spaces where you cannot see through. So there's distorted vision, blurred vision, and then sometimes difficulty seeing in dim light. Now, age-related macular degeneration is an irreversible cause of vision loss. And so this is something that needs to be identified, and if needing treatment, treated early. So what are some risk factors? Family history is a very, very strong risk factor, probably one of the strongest. We are still doing a lot of work to understand it, but we do know that if your siblings or your parents have macular degeneration, you are at very high risk. Now, then we talk about what's a modifiable risk factor or not modifiable. You can't modify your family history, you can't modify your age, but you can modify certain risk factors such as smoking. And this is the number one most important modifiable risk factor. When patients present with macular degeneration, we often let them know that their risk of progressing from the dry kind to the wet kind and having vision loss is significantly higher if they continue to smoke. And so we really encourage patients to stop smoking. The sooner, the better. High blood pressure, heart disease, risk again is not much higher in women than men. Some studies are varied, but it really is important to get evaluated for this. And what are the treatments? So patients can be treated with injections. There are injections mostly for wet macular degeneration that you may hear about, but now we have some new treatments for dry that can potentially delay the progression. How can patients prevent macular degeneration? There are AREDS 2 supplements. You may hear about them, Preservision, Ocuvite, over-the-counter supplements that you can attempt to help decrease your rate of progression. Quit smoking, as we talked about, well-balanced diet and exercise. Okay, so then retinal detachment. This is another irreversible cause of vision loss to a degree. We can do surgery for it to repair it, but it can still cause irreversible vision loss. So this is when the retina lifts away from the back of the eye. There's a vitreous jelly at the back of our eye. As that liquefies, it separates from the retina. And when that happens, it can cause a tear. This is generally an emergency. Patients who present with this need emergency surgery anywhere from 1 day to 7 days later. Risk factors are age, trauma, nearsightedness, because the nearsighted eyeball is longer than your average eyeball, recent eye surgery, maybe a recent glaucoma surgery or cataract surgery, areas of thinning of the retina, and a family history of retinal detachment. So symptoms, patients may describe flashes of light, a sudden gush of hundreds of new floaters, or a shadow or curtain in your vision that's continuing to get worse. A shadow or curtain that comes and goes is different, but one that's there and it's continuing to progress. We can do a few different procedures for this. One of them is an in-office pneumatic retinopexy. It's not as successful as some of the other procedures. There are very specific patients that may qualify for this. And then there's surgery, actual surgery in the operating room for this. As I mentioned before, it is an emergent or urgent surgery that needs to be performed. So very quickly, I'm just going to touch upon medication toxicity. Over time, patients who are taking hydroxychloroquine, this medication can deposit in particular cells in the body. It can cause damage to the retina. Pentosan polysulfate sodium. This is really critical here. Patients who have interstitial cystitis and are on this medication may have toxicity to their retinas. And this is something that's only really come to light in the last few years. So it's really encouraged that these patients have eye exams. Medications for osteoporosis, ovarian cancer, breast cancer, tuberculosis, and antipsychotics. So how do you care for your aging eyes? Regular ophthalmologic examinations. It's not always an annual examination. We often recommend once you're around 50 to go in and get an examination, and the doctor can indicate to you how frequently you need to come back because they can pick up on some of these things. Quit smoking, as you've heard a number of times throughout the night tonight. UV protection similarly, a nutritious diet, and an active lifestyle with exercise. So these are some resources where you can find more information. And thank you all very, very much for your attention tonight.
I'll be happy to answer from the neurology perspective. cortisol, elevation of cortisol levels increases it's a result of could be a result from like a hormonal problem, but also it's a response for stress. It's like a fight or flight mode. So that activates a whole chain of hormonal changes, but also inflammation, and the blood pressure, increasing blood sugar, gain weight, poor sleep as well, and it can also like cause like some anxiety, and it's toxic for the brain as well. Too much cortisol is toxic. Little cortisol, people will die. But they they will not be doing well. So that's the from when you're stressed and you're in a fight or flight mode, the brain cannot think properly. All that anxiety and stress occupies too much real estate in the brain, and it doesn't it's not like an ideal environment for cognition.
Adding on to that, high cortisol levels are associated with inflammation. It's a negative metabolic hormone, so can be associated with high glucose levels, higher blood pressure, and in a pathologic state, can impact bone health negatively. So definitely best to, modulate cortisol levels.
This is a really, really hard question to answer as a one size fits all approach, because there are so many things that factor into this topic in general. In a very broad sense, basically any different type of cancer therapy, including radiation, immunotherapy, chemotherapy, all different types of cancer therapies can have multiple different spectrum of cardiovascular complications. And those, by the way, can be right away or they can be over the long term. And this sort of intersects with thinking about just patient risk. So some of the things I was talking about before, like what kind of cardiovascular risk do you start your process with? Do you develop along the way? Are you an older woman who's postmenopausal with high blood pressure and diabetes? And then you get certain types of chemotherapy. So it's the reason I say it's not one size fits all is because there's so many things that factor into how we think about risk. At the end of the day, any cancer therapy can cause any issue. It can cause high blood pressure. It can cause problems with the pumping function of the heart failure, heart attack. And so that's why it's just really, really important for women to be very in tune with what type of therapy they got, keeping track of the doses if they can, and being empowered to kind of ask your oncologist and your primary care. And if you have a cardiologist, or if you don't find an appropriate person, to refer to a cardiologist so that you can really have a good individual risk assessment.
So hair loss is really difficult, and there can be a lot of factors. Obviously, there are some medications that we know can contribute to hair loss. It probably makes sense to be evaluated by a dermatologist just to make sure the medication isn't the only kind of risk factor. There may be other things that can be done, but I would think it's worth having your scalp examined and exploring really your full medical history.
I guess if I could just ask as an aside, because I'm often asked this question, because a lot of my patients do have hair thinning with these drugs. What about supplements? Should they be taking, I won't mention any kind of brand names over the counter, but there's lots of companies that have hair growth supplements. Is there any credence to those?
I don't think, across the board, I could make any general statements. In general, I wouldn't recommend taking supplements for this until you kind of review with your doctor. There are a lot of components to these supplements that can be harmful or can impact lab results. It's tempting. There's a lot of advertisements online, and, especially if you're going through this, you're probably actually getting targeted advertising. It's tempted to grab something off the shelf, but I wouldn't jump to anything specific right now.
Often I have patients just keep a small bottle of over-the-counter lubricating eye drop by their computer. As the day goes on, generally around noon, I recommend they can put a drop in every couple of hours just to keep their eyes comfortable and moisturized. In the end, for the most part, patients are not necessarily doing harm to their eyes by not lubricating them. It's just very uncomfortable. And that's, there are obviously extremes on both ends, but most patients just feel uncomfortable when their eyes get dried out at a screen. They're not necessarily permanently damaging their vision. That's usually what I would recommend.
So I want to take this opportunity to thank our incredibly excellent panel for participating, and thank you to all our participants in the audience.